Good afternoon. Thank you for participating in our monthly virtual Lunch and Learn lecture series. Today, we will be discussing the basics of testosterone deficiency. After this lecture, you should understand which testosterone treatments work best for certain patients and key points of appropriately working up hypogonadism. Joining us for today's lecture, we have Priyanka Borelli. Dr. Borelli is a clinical assistant professor of urology at the University of Arizona College of Medicine, Tucson, and a urologist at Banner University Medical Center, Tucson. Welcome, Dr. Borelli, and thank you for joining us today. Please go ahead and take it away.
Hello. Welcome to our talk today, which will be talking about managing testosterone deficiency. So no disclosures, some highlights of what we will be talking about today. So, full disclosure, I don't think this is the most interesting topic necessarily, but I think that this is something that is becoming a little bit more frequently seen in both urology and probably the primary care space. So I think it's important to feel comfortable with certain concepts surrounding treatment, the basics of management, and potentially even some red flags or things that you don't necessarily want to miss. So I think this diagram is important because for me, it explains our initial workup. It explains how I decide which monitoring labs to get, how we counsel patients on the short-term and long-term effects of testosterone, and how we decide what agents we use for certain patient populations. What this diagram is showing is that, just kind of basically starting at the top, your hypothalamus will stimulate your pituitary, which will then stimulate the testicles to make testosterone and to some degree estrogen. Testosterone and both estrogen will negatively feed back on the whole system such that when there is enough, this whole system gets downregulated. So potentially one of the main things to kind of take away is that men who begin testosterone treatment, they will ultimately shut down their own native testosterone production. Another important point is that, so the pituitary, it secretes luteinizing hormone, and that is what stimulates testosterone production, but it's also important to know that it's going to stimulate to some degree estrogen production as well. And then, of course, some of the testosterone that gets made, it does get converted to estrogen kind of peripherally. So I think all of these kind of concepts are important to bring up in discussion with patients because I think they come in and they think this is just a quick fix to a lot of issues, but there are some potential side effects that can happen. And I think they should also understand why we're checking all the labs that we do. So this is just kind of that summary for what I said. So the main points, again, is just that really telling them that they're going to be shutting down their own biologic production, potentially more estrogen. And I use this diagram to also explain things that you don't want to miss. So one thing you don't want to miss is that you could potentially, in your initial workup, you could potentially actually discover something higher up that might be going on. Such as, a brain mass or some kind of pituitary adenoma or a prolactinoma, things like that, certainly you don't want to start someone on testosterone and have missed something like that. All right, so some potential, benefits of testosterone treatment, which, as you can see, seem very appealing. And this is kind of, what patients are expecting as well. Improved lean body mass, bone strength, sexual function. And of course, a lot of these patients have already done their homework and this is what they're expecting. So not everything is as black and white as it seems on commercials, of course. And in fact, all of these potential benefits really lie in a gray area. And to start, most of these studies are actually based off of, retrospective reviews. That's a lot of what we have. So, for instance, with regards to sexual function, some things for patients to keep in mind and that I remind them of, for instance, libido and response to medications such as Viagra and Cialis. In most of those studies, the improvements were actually most pronounced in men that had lower baseline testosterone levels. And this is levels, like in the 100s, 200s. And it's been shown that over supplementation of testosterone and what we consider to be eugonadal men, so people who have relatively normal testosterone levels, it's not necessarily going to improve their sexual function or libido. So again, a lot of these things can be in somewhat of a gray area. So on to the initial evaluation. This is kind of your initial basic workup. And this is really based off of the American Urologic Association guidelines. So the patient should have 2 morning testosterone levels. I usually tell them before 10 a.m. is fine, does not have to be fasting. You should check a luteinizing hormone to try and determine the etiology of their low testosterone. And as you recall in that, previous diagram that I showed, in a normally functioning axis, if testosterone production is low, then your pituitary gland should really respond by ramping up its LH production. So it makes sense that if someone's testosterone is low, you expect their LH to be high. That's indicative of some form of primary testicular failure. The body is doing what it needs to do to try and increase testosterone production. So typically no further workup is really needed in those patients, of course, unless fertility is an issue. But in a scenario where the testosterone level is low and the LH is really low when it should be responding differently, then your body is either not recognizing that the testosterone levels are low or it's unable to respond appropriately. So, potentially something higher up on that axis is happening. So you can get a prolactin level to evaluate for a prolactinoma. But if your prolactin is fine and your T is very low, like below 150, and your LH is low or just unusually normal, then an MRI brain is recommended because you can have other non-prolactinoma adenomas in the brain, and it may just be compressing the pituitary gland and preventing the appropriate response. So some other recommendations are listed here. You can ask the patient about gynecomastia. You should measure an estradiol level. If they are a patient that is interested in fertility or they have been struggling with fertility, then an infertility evaluation should be done before starting anything at all. And if you're starting a patient on testosterone, then you really want to get baseline levels, and this is what I do, of estradiol, so their estrogen levels, their hematocrit. Make sure they don't have a baseline elevated hematocrit and have a higher risk of polycythemia. And then particularly men who are older than 40, you should be getting a baseline PSA because these are all things that can be affected by testosterone treatment. And this is how I kind of carry on with interval monitoring, and I think a lot of urologists do it this way as well. So typically, if you start someone on testosterone, try and get some labs not too far out. So I wouldn't say, I'll see you back in 6 months and we'll see how you're doing. I typically see them, 6 to 8 weeks afterwards, check these labs. Technically, the goal range, and according to the guidelines, what we should be treating to is between, 450 and 600. Obviously, it can vary from patient to patient, and you kind of have to take that into account. Hematocrit, you kind of want to be below 54. And if your hematocrit is running on the higher side, but you've also noticed that your testosterone levels are high, you can really just adjust your dosage. But if the testosterone is in a reasonable level and your hematocrit is still high, then those are patients that should be considered for what we call therapeutic phlebotomy. And it's, essentially blood donation, but it kind of reduces that risk of polycythemia. And then once you've got an established patient and they're on a good regimen, hormones have been fine, typically, you can check testosterone hematocrit every 6 months, check PSA according to regular screening, and you can check estradiol on certain patients, kind of depending on their response and what their historic response has been. So, in the interest of time, I'm going to just kind of briefly go over the different kinds of hormonal agents that we can use. But of course, it's always a good idea to counsel on weight loss and exercise. And certainly any patients with sleep apnea or sleep disorder should be treated for those as well. And I'll kind of touch upon that later as to why that's important. But we've got gels, patches, injections, various forms of topical, subcutaneous pellets. And then I'll touch upon these alternative agents that we use if direct testosterone doesn't really seem appropriate. So here's your gel. They typically come in concentrations of 1%, 1.6%, 2%. They're fairly common. And at the end of the day, what you use, honestly, is going to depend on insurance coverage. But the studies have shown that steady state levels are often achieved within 24 hours, and up to 85% of men will achieve testosterone levels in a normal range. But you just have to keep in mind that absorption rates can vary. So some men may need more adjustments than others. I personally, again, it depends on insurance coverage, but I often start with the 1.6%. And if you need to make adjustments, you can adjust the concentration, you can adjust the number of applications. Just try not to change too many things all at once. An important downside to topicals that people should be counseled on is that you can transfer it. So, they can transfer it to their partners, to their kids, to their grandkids. And so that's something that you really need to discuss with them. They need to wash their hands after they apply it. It should be to an area that is going to be covered. So, the back of the shoulder is a pretty common place. There's a patch. This is a patch that you would apply every 24 hours, and testosterone levels are directly proportional to the skin surface area that is exposed to the medication. So you want to choose an area that's large enough, like the back or the thigh. The most common side effect is skin irritation. I will say that it's probably a huge reason why it's just really not used often, or patients just end up stopping it. And then the second reason would, again, probably be insurance coverage. I think that's a fairly big reason as well. All right. And then there's this pill that came out within the past 5 years. So oral testosterone was never really available due to concerns with liver toxicity. This pill, it's essentially testosterone undecanoate, and the brand name is Jatenzo, and it came out in 2019. That's what most of the studies are on. It's an option, but it's fairly new. There's not a lot of long-term data on it. And quite honestly, I haven't really found that it's been covered by insurance, and out of pocket, it's quite expensive. So it's really not being widely used at this point. But the studies have shown that on average, people reached testosterone levels between 500 and 700. And kind of the main adverse effect is that the blood pressure might increase very slightly, but it's very, very slight. And then we have an intranasal option that, again, kind of came out in the past 10 years. The appeal of the intranasal option is that it's thought to preserve the hypothalamic pituitary axis and fertility, since it's short acting and it's kind of delivered in this pulsatile manner. That being said, it's something that you have to do 3 times a day, which is kind of onerous. And again, insurance coverage cost, that all plays a role. But I think important to know that it is an option for patients who are interested in fertility. And then intramuscular is probably what we use the most. The main difference between the different types of testosterone are injections are the carrier oils, how it's prepared, and the half-lives. So testosterone cypionate and testosterone enanthate, they are fairly similar in terms of half-life, which is around 7 days. Enanthate can be a little bit more involved to prepare, can sometimes have more preservatives, maybe a little bit more uncomfortable to inject. So cypionate is probably what we use the most in the States. And decanoate is usually administered every 10 weeks or so in the office, and that half-life is closer to like 90 days. So, my personal practice, I tend to start people, I think it's easier to start people on a lower dose and then up titrate rather than going in the reverse direction. So I tend to start people with 80 milligrams weekly. And if ever you're going to adjust the dosage, you should kind of adjust it in small increments, like 20 milligrams at a time. You don't want to get any drastic changes. And something else I would say is that very rarely should a patient ever require more than 200 milligrams weekly. If that's the case, something is not right. And those are usually the patients that end up having a really long history of testosterone use or steroid use, or have been getting treated by someone at an outside clinic to these super therapeutic levels. So I would say that's definitely a red flag. If a patient is coming to transfer care and saying that, oh yeah, this is my dosage. And along those same lines, if you have someone on a certain dose, like 80 weekly, and they tell you that it kind of works okay at first, and then it kind of tapers off very quickly. The answer is not always necessarily to just increase the dosage. Sometimes you've got to tinker around with how frequently they're doing the injections, and maybe there's someone that needs a lower dose more frequently. So I think it's important to get the appropriate history from the patient and not land them on this big whopping dose. And then there are subcutaneous injections or pellets. So there is a testosterone enanthate auto injector, very convenient, makes it so that patients can't, really, I guess, so to speak, mess up the injection. But again, cost and insurance coverage is an issue. There are pellets that are very frequently done. They're placed in the office, just subcutaneously in the outer buttocks. And peak T levels can actually be reached almost like 12 hours after insertion, and the half-life is around 70 days. So works well, but obviously it's a office procedure. So which one to use, right? Again, unfortunately, insurance coverage is probably going to play a huge role, access to medication, and of course, patient preference. But any of these are safe and reasonable options. For the topicals, like the patch and the gel, the benefit is that there's no needles. You can get a steady state because you're doing it every 24 hours. Of course, the downside is that the efficacy really depends on absorption. And the patch can cause irritation. The gels can be transferred, as I said. Between the two, gels are probably more commonly used. The intramuscular injections are the most widely used. They work really well. They're cost effective, even if you have to pay for it out of pocket. But of course, it means injections. You can get highs and lows with regards to the levels. And then you've got the pellets. Those can give you a steady state, but again, it's an office procedure every 3 to 6 months. Sometimes I think it kind of works better for some patients who live in one area for, periods of time, and they know they're going to be out of town for like 3 or 4 months. And so for some of them, it can work well. Um, so that's kind of a quick summary of who may kind of benefit more. Um, all right. And then one other thing I would mention is, again, kind of along those lines, if you're treating a patient and their levels are great, but they tell you that symptomatically they're feeling no improvement whatsoever. They're like, I feel no change. Um, then again, instead of increasing the dosage, I think it's, probably time to explore potential other etiologies rather than their low testosterone as a source of their symptoms, which often includes, like low energy, fatigue, things like that. All right. So, alternative agents. These are agents that are usually considered for patients who desire fertility preservation. Most of these are off-label uses. And I'll briefly go over these because I think if you're seeing a patient in the office with low testosterone who's struggling with fertility, or wants to preserve it, it's kind of helpful to have a general concept. But I do think that, if they're interested in preserving fertility, probably a good idea to see us in the office. Um, all right. So clomiphene, something that everyone is very familiar with, been used for a variety of pathologies, but it's an estrogen receptor modulator. So you're basically just shutting off that negative feedback of the estrogen. And you just end up ramping up this whole axis and just making more of your own testosterone. Um, but, it really only works for people that where their own system isn't ramped up already. So, keep in mind that estrogen levels are going to go up. I have found that pretty much all my patients on it, their estrogen levels go up. So you have to be aware that that has to be managed as well. But the idea is that the testicles are producing their own testosterone. And so in those cases, fertility is preserved. Um, Anastrozole, again, another medication that everyone is familiar with in different settings, but it prevents the conversion of testosterone to estradiol. So I think it's a good option for people with high estrogen levels, either at baseline or as a result of being on something like clomiphene. Um, in general, when using an estradiol, you still want to keep estradiol levels within a reasonable range. So if it's too high, you think about this theoretical risk of forming clots. If it's too low, you worry about bone health and osteoporosis. And so that's where this comment of a DEXA scan comes into play. With regards to that, there are no specific guidelines for men who are on aromatase inhibitors. So we kind of go based off the guidelines that were set for women with breast cancer who are on these medications. So again, not a hard and fast rule, more of an adaptation. But again, just consider a DEXA scan every 3 to 5 years if you are going to be someone that uses this. And then HCG, again, mostly used in patients who are trying to preserve fertility, can be a little bit tricky to manage. So I think if you're considering putting someone on HCG, probably a good idea for us to see them. All right, so adverse events. I alluded to this, but polycythemia, we'll talk about cardiovascular events, prostate cancer, fertility, and just dependence in general. So for cardiovascular events, realistically, there's no good data to show that testosterone treatment directly increases cardiovascular events. And some studies actually show that, low testosterone may be associated with cardiovascular events. So could it be that testosterone treatment for the right patient may be actually cardioprotective to a certain extent? Possibly. But again, the lack of good data really makes people nervous. So That being said, according to our guidelines, when someone has an event such as heart attack, stroke, we typically, stop the testosterone and don't consider restarting it for 3 to 6 months after that event. Um, the next, not necessarily adverse event, but something that needs to be kept in mind is fertility. So in contrast to, what we just talked about with cardiovascular events, the data related to fertility is very clear. Exogenous testosterone treatment will shut down sperm production. So it is always important to ask about desire for fertility. On average, it takes about 3 months following discontinuation of testosterone therapy to recover sperm production. But in some cases, it can take, up to 2 years. Um, and so I think it's definitely worthwhile to have that discussion before you put someone on testosterone, because it's really unfortunate when someone is trying to come off of it. And, again, if it takes 3 months, 6 months, 9 months, if there's a female partner that's involved, timing obviously is very important. And so, sometimes they end up having to go towards assisted reproductive techniques when, maybe they wouldn't have had to have done that if they were just not put on testosterone in the first place. And of course, that's a huge emotional, physical, financial burden for a couple to have to go through. Um, Polycythemia. So the Endocrine Society recommends keeping hematocrit levels less than 54. So that's kind of what we use. Testosterone supplementation is associated with about a 3 to 4 fold increase risk of having a hematocrit above 50. And it is a dose dependent increase, which is why I said, if you have someone with a high hematocrit and their testosterone is also kind of unreasonably high, just reduce the dose. Does this directly translate to an increased risk of having an event like a stroke? Not necessarily. It's more of a hypothetical risk, but obviously something that we stay very vigilant about. So, in order of this just shows the risk of polycythemia. So injections probably have the highest risk, and then it goes pellets, topicals, and Clomid with the least. So let's talk about prostate cancer. We know that testosterone does likely increase prostate volume because someone gets converted to DHT, which may also explain the slight increase in PSA after starting testosterone for some patients. That being said, studies haven't really shown a major worsening of urinary symptoms, although anecdotally I have seen patients report that. But there have been multiple retrospective studies looking at patients with treated prostate cancer, either through radiation or surgery, and there was no increased risk of cancer recurrence in the studies. So, as you can imagine, the cohorts were small and they're obviously retrospective, but both the American Urologic Association and the European guidelines, they essentially say to, use your clinical judgment when using testosterone therapy in men with treated prostate cancer. So, I guess my point is that, men with treated prostate cancer, they can be candidates for testosterone therapy. And it just kind of has to be done in a shared decision making space. And that's certainly something that we are happy to help with as well. But some things that I keep in mind is, or that I'm considering when I'm starting someone with a history of prostate cancer on testosterone, I consider whether or not they had high risk prostate cancer, how far out from their treatment are they, do they have surgery versus radiation? With radiation, obviously there's still prostatic tissue present. So, I always, whenever possible, try and communicate with the patient's on medical or radiation oncologist, just also make sure that they are on board with testosterone treatment. Obviously, if the PSA does go up on testosterone therapy, we have to consider further testing the way that we would for anyone with that elevated PSA. And if in our studies, we detect prostate cancer, we would stop the testosterone treatment. All right, and then dependence. This is something that I always communicate prior to starting testosterone therapy, because I've had a number of patients that come to see me to actually try to get off testosterone, um, because they were started at a men's health clinic somewhere, and they tell me that if they knew that it would be so hard to stop it, they would have never started it in the first place. And it's just, again, you take exogenous testosterone and you stop your own testosterone production, and it takes months to try and get it back, and it's like withdrawal like anything else. So you kind of have to very slowly come off of it, and some people just in the end aren't able to. So whenever I start someone on testosterone, I tell them that they should expect that it would be this like lifelong therapy. Some other things that you should mention is that because they're not producing their own testosterone, you can get a degree of testicular atrophy. And sometimes that is not always reversible, even when you stop the testosterone. So overall contraindications, untreated prostate cancer, certainly breast cancer, men who wish to preserve fertility, untreated sleep apnea. So the idea behind this, so first of all, sleep apnea and sleep disorders, the idea is that men who have interrupted sleep or poor sleep quality, that may be contributing to their low testosterone in the first place. So definitely a benefit to try and address that, because that may be something that, avoids a medication for them, as far as testosterone goes. But the other side of this is that giving someone testosterone who has, untreated sleep apnea, there are a lot of hypotheses that it could make the sleep apnea worse. Some ideas are that higher testosterone levels lead to these higher metabolic demands and increased oxygen consumption, or perhaps increased circulating hormones may impact, the neural response pathways to hypoxia, or has some kind of peripheral changes, neuromuscular changes to the airways. There's a lot of different hypotheses. So nothing is really certain, but it is recommended not to treat people with untreated sleep apnea, because it might worsen that. And then again, we talked about not starting it after a cardiovascular event kind of immediately. And if they've got an elevated hematocrit at baseline, it may be worth exploring before you start someone on testosterone therapy and start chasing something kind of after the fact. And kind of finally, I think it's important to discuss a trial and discontinuation with the patient. And I think it's best to discuss this before you even start treatment, and just explaining that if there is no symptomatic benefit despite being on or being at therapeutic testosterone levels for 6 months or so, then we should really consider just stopping it. And so that's why I think at the end of the day, your initial visit is probably the most important for establishing, not just ground rules, because testosterone is a controlled substance, but discussing the need for ongoing labs and visits and compliance and this trial of discontinuation. Also, the possibility that due to insurance and national shortages, the patient may have to switch to another agent, or there may be, a short gap in their treatment. And it's not necessarily, the office's fault for that. We can't always control that. And then, of course, the fact that this could be a lifelong treatment. So I really value setting goals and expectations kind of right at the beginning. So just kind of going back to that initial slide with things that I wanted to make sure we all kind of got out of this. So for the initial workup, make sure you check those gonadotropins. That's the LH, looking to try and figure out the etiology. You'd be surprised with what you find sometimes. PSA for men over the age of 40. Does everyone need testosterone treatment? Short answer is no. But when you are treating someone, don't treat them over 1,000. That's considered super therapeutic and is not necessary. As far as which ones for which patients, we kind of summarized on that slide, but injections work great. There's going to be ups and downs. Gels may not be as quick onset or obvious a response, but it can sometimes give people a better steady state, so for the right person, it might be better. And then when not to use it, obviously prostate cancer, for someone with a history of prostate cancer, never a bad idea to see a urologist. Same with patients wanting to preserve fertility, or if you're having trouble kind of maintaining appropriate levels, they're just up and down and just hard to manage, or unable to reach a good level. And then again, not to prescribe more than 200 weekly. And those are probably kind of the main takeaway points, I would say. That's about it. I have, for anyone that may be interested, there are many references here. But if anyone has any questions, I'm happy to answer them.
Thank you, Dr. Borelli. Are there any questions, comments, anything? I'm seeing thank yous come through, but no specific questions. I think you did a great job reviewing this information and presenting it in a way that they can take it back and use it in their practices. Thank you for your time this afternoon. We will look forward to seeing you guys next month.
Great. Thank you.